right, so welcome everyone to the Evaluation and Management Problem Questions and Answers webinar. My name is Ellen Vera, and I'm a specialist with our Provider Outreach and Education Department of WPS. On the line with me today, I have Aline Ziegler, my friend and colleague, and she's going to be monitoring the chat for us. We did receive several questions today or through the registration process concerning time, concerning the data element or the risk element. There were other questions in there for different categories of services. Those questions won't be part of this presentation today. We are going to concentrate on the problem element of medical decision making. You can access our YouTube playlist for evaluation and management for further information on these additional questions. The next thing that we have up for you is our disclaimer. As you can see here, this education is as accurate as we can make it as of today. CMS rules and regulations, however, are the final determinant of coverage along with your documentation. We'll provide responses to your questions based on the facts given in the question, but again, Medicare rules determine final coverage. CMS does prohibit recording of this presentation for profit-making purposes. If you're doing screenshots, if you're recording this, we would ask that you not do that. We are recording this and we will be placing this on our website under the Training Center. That's a topic center at the top of the screen, under Training Center, and then under the Encore page. We will also be placing this on our YouTube channel, and that should be available on our YouTube channel probably within the next week. We're also going to be providing you with several opportunities to take a survey on this presentation today. And that's effective for both those of you that are listening live and those that are watching later on YouTube. If you're on YouTube, you can just take your scroll bar, take it all the way to the end, and then that survey information will be there for you. So one of the things we want to tell you about before we get started in our presentation is that, let me change this here real quick, is that the interactive voice response system, the eligibility function within that is going to be discontinued. This is a directive from CMS, and you can see there that it will be discontinued as of 3/31 of 25. Eligibility resources, you still have those. You can go through our direct portal. You can go through the direct data entry, and you can do what's called HETS, or the HIPAA Eligibility Transaction System. Now we have the change request listed for you there, the 13754. CMS has not published that yet, which is why we don't have that linked. But we want to just let you know that after 4/1 of 25, you'll need to be using the secure portal, the DDE system, or HETS in order to get your eligibility information. So what are we going to talk about today? We're going to provide a brief overview of the problem element of the medical decision making. Medical decision making is one of the two ways that you can choose your level of service. Time is the other way, and problem is one of the elements under the medical decision making. So what we're going to talk about is what you would be looking for in the documentation to determine if a problem is addressed as opposed to simply listed there. And then we're going to open it up for questions. We have received some questions on whether or not modifier 25 is appropriate on the E&M service when you perform a procedure. And this presentation itself is not going to go into a lot of detail on modifier 25. However, we do have a modifier fact sheet available on our website. We also have YouTube videos that are available on this particular topic. And the documentation that you need to evaluate, or what you're evaluating for, is really the definition of the modifier. A significant, separately identifiable service. Significant meaning a great amount of additional work. Separately identifiable, meaning that the evaluation and management service can be separately identified from the E&M that is built into the payment for that procedure. Again, we had some questions on data and risk. We do have future webinars planned on those. Again, you can still sign up for those. We completed either last week or the week before a question and answer session on time, and that is available on our YouTube channel right now. So the next thing we have is just some acronyms for you. These are some ones that we'll be using as we go throughout the presentation today. The first thing that we have listed for you here is the Social Security Act's definition of medical necessity. And so you can see here, services have to be reasonable and necessary for the diagnosis or treatment of an illness or injury, or to improve the functioning of a malformed body member. So this is the very first thing that Medicare or any of the Medicare contractors is going to be looking for in that documentation. What made that service medically necessary for that patient on that particular day? How does the documentation support that? How does it show within that documentation what you're diagnosing, what you're treating? Sometimes you're going to have a diagnosis code. In some situations, you're going to have symptoms. You have abdominal pain. You may not know yet exactly what's causing that or what the diagnosis is for that, but you're treating that illness or injury. And so that's what we want to see within the documentation as far as the problems are concerned. What is your physician or practitioner treating for that patient during that particular encounter? Now, this slide just reminds you of the changes that the American Medical Association made. The changes were effective January 1st of 2021 for office or other outpatient services. And then January of 2023, they included all of the other categories of service. You can see there that you can choose your level of time, or choose your level of service rather, based on either time or medical decision making. One of the questions that we get quite often is, do you have to use one or the other? And the answer to that is no. You have to use one of them, obviously, but if the time that is documented, if that's more advantageous to you, bill based on time. If the medical decision making is more advantageous to you, then bill based on the MDM. You have two exceptions to that. Emergency department services can only be billed based on the medical decision making. Critical care, of course, is billed based on time. When determining, when looking at your documentation, you really want to be looking at what is your practitioner addressing for that particular patient. So you can see on this slide, we have the categories of MDM: number and complexity of problems addressed at the encounter, amount and complexity of data reviewed and analyzed, and then your risk. So again, today's presentation is going to concentrate on that first one, the number and complexity of problems. So the information you have up on your screen is the CPT, or the American Medical Association's definition of a problem. This is what your practitioner is going to be documenting as to what he or she is treating or evaluating during that particular encounter. Again, you may not have a diagnosis yet. You could have a patient coming in with abdominal pain. You may not necessarily know what's causing it, but those symptoms, the information that the patient's providing to you, that's all part of the problem identification and the problem section of your medical record itself. Now, when we're talking about Medicare patients specifically, we're talking patients who are over age 65 or patients who are on Medicare based on a disability. These patients can have a lot of different problems. But what we need to see in the documentation is specifically what is your physician or practitioner treating today during this particular encounter. Patient has 27 different diagnoses, but today we're treating the patient for a rash on the elbow. That's what we're going to be looking for within the documentation. Um, when coders and billers are looking at the pieces of documentation, you can use your expertise to determine the problems and whether or not they were addressed. Um, you can also look through the information in the CPT to determine the level of the problems, but that documentation has to support it. If you can't find it, if you can't determine within your documentation what those problems are, then you're going to have to go back to that physician or practitioner for more information. Remember, if we review and we don't agree, then that practitioner is the one who's going to be reimbursing Medicare. So bring them into the conversation. So the next thing that we have then is the problem that is addressed. So it tells you here, your documentation has to show that that problem is addressed and managed during that particular encounter. So let's talk about that one for just a second. You can also consider a problem addressed if your practitioner's documentation shows a consideration of that problem in order to deal with the problem that has caused the encounter. So let me give you an example of that. Patient's reason for the visit today is pain in the knee. After consideration of the treatment, you're also addressing and analyzing the diabetes for consideration of whether or not to give the patient a steroid injection. So you're looking at that diabetic condition. Is the steroid injection going to affect the diabetes? Is the diabetes going to affect the steroid injection? It's called proof of thought. So this is where your practitioner is going to indicate within their documentation, patient's last A1C level was over 9, therefore I need to do this instead. Or patient's last A1C level was under 6, there's no consideration. If there's no documentation to support that that problem was addressed, then when we review the documentation, we're not going to count that as a problem. You really want to get your physicians and practitioners away from blanket statements such as all chronic conditions addressed. How did they address them? Is it at goal? Is it not at goal? Are there complications going on? If the statement all chronic conditions addressed without anything else within the documentation is not going to help your physicians and practitioners. Medicare needs to see specifically what was addressed. You can consider all of the problems that were addressed during that encounter. So a patient comes into the ER because they passed out, for an example. Well, the patient or the physician discovers during that encounter that the patient has a tumor visible through that patient's eye. Well, so we've got the patient passed out. That's the reason for the encounter, but now we also have the tumor that we have discovered. And so that's the problem that we are addressing at that point. There's an acronym out there, COPA, COPA, which stands for Complexity of Problems Addressed. The CPT and the AMA information gives you information under the problem, which I'll show in just a second, about what goes into each of the different categories. Um, if it's just listed within the documentation, but it's not actually addressed, then you would not count that towards your level of problem. You could also have statements that the condition is managed by somebody else. Well, if it's being managed by somebody else, you wouldn't count that as part of your problem addressed unless your physician or practitioner is either evaluating and managing that, or that comes into play with what they are evaluating and managing. So what you have on your screen now is what's considered a straightforward problem. So it's a self-limited or minor problem that runs a definitive and usually pretty straightforward course of treatment. It's not likely to permanently alter health status. However, the definition and the problem that you're addressing is specific to that patient. So let's say that you have a patient with hypertension. A cold could meet this. However, if you have a patient with severe chronic obstructive pulmonary disease or COPD, a cold may not be a minor problem for that patient. So you need to evaluate what's going on with the patient and how that affects the particular problem. This could fall, again, a cold for a patient with severe COPD could fall into the undiagnosed new problem with an uncertain prognosis. But you want to look at that documentation on how that physician or practitioner is addressing that problem. Excuse me. If they're addressing it as a cold, simply a cold, even for the patient with severe COPD, and they're not documenting that additional proof of thought, that additional consideration, then that cold would fall under the straightforward. The next one that we have is the low, an example of that. And you can see just a couple of them, a stable chronic illness, stable acute illness, etc. So let's talk about some of those. Well, a stable chronic illness is where the patient is at treatment goal. Number one, a chronic illness, according to the American Medical Association, is an illness or injury that has lasted or expected to last at least 12 months. You can see we've got on the screen here 1 year. Diabetes is a condition that's mentioned often. Your patient's medical record will determine whether there's a consideration that this could be a new problem, could be a diagnosis of diabetes. Same thing for high blood pressure. So when we're talking about stable, it means the patient is at treatment goal. So what is that goal? If the goal for your diabetic patient, as an example, is an A1C less than 6, are they at that goal? If they're at that goal, then it could be stable chronic illness. If they're not at that goal, then it doesn't meet this definition, and you'd need to look at one of the other definitions. Acute uncomplicated illness or injury. We have a patient again coming back in. They had the cold, but the over-the-counter medication is not helping. There's possible considerations of steroids or other medications. Another example could be a patient with a rash due to poison ivy, but the itch and the rash are not resolving, but they're not necessarily getting worse. Uncomplicated on this one is going to be that physician or practitioner's determination. Is this uncomplicated for this particular patient? A stable acute illness, you can see that one. Um, an example here could be a patient has a sinus infection. The practitioner started treatment, and while it's not totally resolved, the patient is responding as expected. Um, One of the questions that we get quite often is if we have multiple problems that fit into several different categories, can we create a higher problem area because of the multiple problems? And the answer to that is no, not according to the American Medical Association. That can create a higher risk, possibly, but not necessarily higher problems. Again, we need to see the documentation on that. Here we have an acute, uncomplicated illness or injury, and it gives you some information on that one. An example of this could be the patient presents to the ER with confusion. They're dizzy. The patient indicates this has been going on for a couple of days. And in this situation, the patient needs IV treatment in order to rehydrate. So the dehydration has kind of been what's going on with them. The next one that we have is moderate, and these are the examples from CPT for you. The first one there is chronic illness with exacerbation. Again, we go back to that word chronic, which means expected to or has lasted at least 12 months, but they're not at goal. So again, we go back to your diabetic patient. They're at an 8 A1C, they're not below 6. So they still have diabetes. You know, they've been at an 8 for quite some time, but they're still not where your practitioners want them to be. So there's going to be additional work required by your practitioners in order to treat this. It could be referrals for nutrition therapy, physical therapy, uh, working to help motivate the patient to make the changes required, etc. Another example of this could be COPD. We'll go back to that one. Patient has COPD, but right now they're in an area where there's a lot of smoke coming from close forest fires or something along those lines. Well, because that smoke is exacerbating that COPD, that means that physician and practitioner is going to have to look for other ways in order to treat that so the patient can actually breathe. Another example you could have would be the patient states they have had back pain for the last year and they're now seeking treatment. Well, now we have a chronic illness because the patient states it's lasted at least a year. This could be chronic with exacerbation as the patient is not at goal because they still have the pain. An example submitted during registration, patient's medication was previously changed. Today, the condition again was evaluated, and there's really no change in the condition, but the patient is having side effects from the change in medication. Could this be a chronic illness with exacerbation? And the answer to that is yes, it can be. Um, Side effects from medications that you have to deal with, etc., that could fall into this category. The next one here is one that gets providers confused. You can see the definition there, undiagnosed new problem with uncertain prognosis. And you need to look at both of those pieces of information when you're looking at the medical record. Number one, it's an undiagnosed new problem. So that means the patient is not walking in the door already knowing what the diagnosis is. So for an example, let's go back to our COPD patient. The family care practitioner has diagnosed the patient with COPD. The patient is now being referred to pulmonary, so this is not an undiagnosed new problem. The patient knows what their diagnosis is. And so you would not count it as this particular level. You would, or this particular definition. You would look at the other definitions for that. In addition to that, it says with uncertain prognosis. So let's go back to our example with abdominal pain. Patients coming in, they have abdominal pain, it's extreme pain. There's all kinds of other stuff going on with the patient. So we don't know why this patient is having the abdominal pain and the level of pain that they're having. But the practitioner is going to document based on their encounter. This could be a high risk of mortality or morbidity. Maybe it could be appendicitis, and it could be getting ready to rupture or a possible rupture. You want to think about the pain level too. There could be other things going on. It could be that the patient simply had way too much broccoli yesterday, or it could be an incarcerated intestine. So that's an undiagnosed new problem with an uncertain prognosis. We don't know what's going on yet, but because of what's documented within the medical record, then it could fall into this category. And then we have an acute illness with systemic symptoms. And we have some examples listed there for you: respiratory, cardiovascular, etc. What you don't include in that is general symptoms such as fatigue, fever, or body aches. Acute complicated injury. This goes back to what does your physician or practitioner believe and how are they classifying that injury? If they're not documenting whether it's a complicated injury or not, if you believe on the documentation when you're reviewing it that maybe it could be, go back to that physician or practitioner. If they don't document it complicated, then you're going to go back to the uncomplicated. So an example of this one could be patient presents for a laceration of their scalp. Based on the information from the patient, the practitioner also performs a neurological exam. Patient is unconscious, they're struggling to breathe on their own. Patient presenting for a follow-up to a fall and experiencing additional problems with balance or gait. Those could be complications. Your practitioner, however, does need to show this within that documentation. And then we go into the high level. You can see there's two listings there. Chronic illness with severe exacerbation. Remember, we had chronic illness with exacerbation before. This is severe exacerbation. That's all going to be based on your clinician's documentation and their proof of thought within that documentation to show how this is severe as opposed to simply an exacerbation. Maybe for this example, the patient's blood sugar has shot to 300. So maybe there's another medication they're on that's causing this drastic rise. A 300 blood sugar, that's going to be severe. We gave the example earlier of the COPD patient and smoke from fires. This could include not only evaluating for medication, but also possible oxygen could be needed until the smoke from those fires dissipates. Again, if you believe it could be severe, but it's not documented, go back to those physicians and practitioners. The last one here, illness or injury poses a threat to life or bodily function. An example of this one could be treating for a urinary tract infection, and there's a very real possibility based on their systemic conditions, based on what's happening with them, that this could move into sepsis. that could pose a threat to their life. Treatment for uncontrolled diabetes causing severe breathing problems. That could be an example of this. And then the further examination and treatment decisions for that patient must be consistent, of course, with this level itself. So that's just a brief overview of the problem element of an evaluation and management medical decision making. What we have up for you now on your screen are some references for you. We've got the AMA or the Social Security information there, the AMA information, a CMS publication on evaluation and management services. And I will tell you that that document, the last one there on your screen, was updated back in September. There's not a huge amount of changes to that, just a couple of lines in there. But if you're looking at an older version of that, then you want to get the new version. I had a pre-submitted question, um, and so we'll do that before we go to the questions in the chat. So the question says, I had a case where the patient had bipolar disorder and recently had an increase in their medication. Today, they say they're doing well with the bipolar disorder, no exacerbation of that. However, the increase in the medications has caused palpitations. They go back to the old dose. Would we consider this to be an exacerbation? It could be. It's not an exacerbation of the illness itself, in this case, the bipolar disorder, but addressing those palpitations could be a side effect of the treatment. So, based on the information that has been given here, that could be a moderate level of problem. So, now we want to go ahead and open it up for questions. So, Aline is going to take a look at our chat and then ask those questions.
Oh, yeah, Ellen, before we get into the questions in the chat, and I want to thank everybody who's submitted questions, just one thing, and this is from the very beginning, when you were talking about the change request 13754 that had to do with eligibility on the IVR, that was published, so I did pop that link into the chat, so I just wanted to clarify that. Our first question today is, would you still list, for example, CHF, congestive heart failure, diagnosis code on a PCP office visit claim if the provider only notes, and this is in quotes, patient sees cardiology?
No, you wouldn't count that one, because your physician or practitioner, the family practitioner in this case, they're not addressing that problem. They're not diagnosing it, they're not treating it, they're not managing it. Now, if that congestive heart failure has an effect on something else that your physician or practitioner is treating, then you could bring that into it, but not if the only documentation you have is it's being managed by somebody else. And just kind of a reminder for you, I'm going to throw this in here real quick. At the end of this presentation, you will have an opportunity to complete a survey, and we would really ask that you do that, and we'll talk more about that when we get there. If you're listening through our YouTube page, through our encore presentations, we would also ask that you take the survey too. Next question, Aline. Thank you.
Absolutely. The next question comes from Karen, and she said, if a patient comes in, for example, an acute condition, and the provider decides to order labs that are due and state the labs are due, can we count?
Okay, so let's kind of break that down a little bit, because I want to make sure I understand the question. Here's how I'm understanding that question. Patient comes into the office for a rash on their elbow. The patient also has high cholesterol, let's say, and so the physician, as part of that visit, also orders labs. Yes, you can still count the labs, because he's also evaluating that high cholesterol. But that also needs to be documented. That high cholesterol needs to be documented within that medical record also. So if I didn't understand that question, then provide me with some more information into the chat, please. Excuse me. Next question.
Okay, great. Would a medication overdose generally qualify as high for problems addressed for threat to life?
The information on the problem level high is there's two. The second one says one acute or chronic illness or injury that poses a threat to life or bodily function. I would think an overdose could definitely do that. So yes, I would look at that as high. Again, documentation has to support.
Okay, thank you. And someone did ask about that change request link. They didn't see it in the chat. I put that in 8 minutes after you started, so if somebody joined after that, they wouldn't be able to see the chat before that. So I did pop it in there again, just so you know why you see it twice. Next question's from Shauna, and she says, what about if a provider sees a patient with a yeast infection and calls it chronic because the patient gets them a few times a year? Is this chronic with exacerbation or still acute uncomplicated because it's intermittent?
Your physician is really going to need to weigh in on that one. It's not a problem that has been continuous, because it is intermittent. But you'll want your physician or practitioner to take a look at that one. Let me go back in my based on the information you're giving me, I probably would go. Hang on, I gotta find my thing. Chronic exacerbation. Um, just based on what you're giving, I think I would probably go with low. You have a stable acute illness, and this is my opinion that I'm providing to you. If you disagree with it, that's okay. If our medical review staff does a review of your documentation and you disagree with that, you can certainly request an appeal on that. I would think this would be a stable acute illness because it is intermittent. And so when they're coming back in, it's a new thing, even though, it's kind of been in play for a while. Next question.
Thank you. Is osteoarthritis considered chronic illness with severe exacerbation?
Osteoarthritis in and of itself could be considered a chronic condition. And then you would determine based on the documentation whether this is at goal, whether it's not at goal, whether there's a complication that goes along with that. The diagnosis code itself won't determine that, or the title of the illness. Let me put it that way, because you've got diagnosis codes that can expand upon that.
Thank you. Next one. Would fractures be considered as complicated injury, or does the doctor have to state complicated?
The doctor would have to indicate the complication, because fractures can go all over the place. You can have a green stick fracture. You can have a break, but you just need to stabilize that and it's going to heal fine. You can have where the bone's sticking out, through the skin, that type of stuff. So a fracture in and of itself would not be the only information you need in order to choose your level of problem.
Okay. All right, next question. Do providers have to document the differential diagnosis they are ruling out to count a problem as undiagnosed? And they give an example: abdominal pain, rule out appendicitis.
You can document that way. That shows what your physician or practitioner is thinking about. But sometimes you're not going to have a diagnosis. Patient comes in with abdominal pain, there could be a whole lot of stuff going on. Appendicitis, twisted intestine, a blockage, cancer of the stomach, ulcers. I mean, it can be all over the place. So your documentation is going to take that abdominal pain as the problem, and then they'll continue on in showing the level of pain, what their proof of thought is, such as the rule out, and then what they're going to do next. But you don't have to have a rule out in there in order to count for that particular level.
Oh, thank you. Next question comes from Melissa. You gave an example for chronic illness with severe exacerbation as a blood sugar at 300. Coders are not allowed to interpret lab results as severe, high, low, etc. So what wording would we ask the provider to use to support a severe exacerbation?
Well, they need to document that. So they could use the word severe. They could use the words, "Oh wow, this is really bad." I mean, it's kind of however they're documenting their particular records. And so if you're unsure, and I realize I'm speaking to coders and billers and people who have CPC designations along with a lot of other designations. So you have a lot of expertise in there. But if it's not documented, you don't want to infer. So you want to go back to your physicians and practitioners. In this case, you would want to go back and query them. Do you think this is severe for this particular patient?
Thank you. What would you expect to see for the documentation to support that a UTI is an acute threat to life?
Well, the doctor needs to tell us that. The statement UTI all by itself, and there's no other information, that's not going to tell us that this is a threat to that patient's life unless that doctor or practitioner puts that within the documentation. One of our contractor medical directors, Dr. Vlahakis, uses the terminology proof of thought. What is your physician and practitioner thinking about for that patient? Because we're paying them, Medicare reimburses for their expertise, their knowledge in treating that patient. And so if they simply put UTI and nothing else, we would not count that as a high level of problem.
Okay. This question is going back to our question about the osteoarthritis. Cassandra wants to clarifying that osteoarthritis is chronic, but the status of that chronic illness has to be further specified. Is that what you were saying?
Yes. Yes. And osteoarthritis, certainly is generally speaking, going to be a chronic illness, but is your patient where you want them to be? With a diagnosis of osteoarthritis or any of the other ones we've talked about, they have that. It's not necessarily going to go away, some of these longer term illnesses or injuries that the patient could have. But are they at goal? If you want your patient's pain level in osteoarthritis, for an example, to be below a pain level of 2, if you want them to be able to do activities of daily living and they're meeting that, then they're at goal. If their pain level, again, you want it at a 2, their pain level is at an 8, then they're not at goal. And so that would be the exacerbation.
Okay, okay, thank you. Next question. Under the AMA NF section, it states, when selecting a level of medical decision-making for nursing facility services, the number and complexity of problems addressed at the encounter is considered. If documentation supports, can the coder use this as overall medical decision-making level?
Okay, read that one again. I'm sorry.
Okay, under the AMA in the nursing facility section, it states, and she has a quote, when selecting a level of medical decision-making for nursing facility services, the number and complexity of problems addressed at the encounter, is considered. If
Yes.
if documentation supports, can coder use this as overall MDM level?
No. You can certainly, count and evaluate all of the problems that are addressed, but medical decision making is you have to exceed the level of the problem, the data, and the risk to the patient. So it's all three of them.
Okay, thank you. And I apologize if I was not reading that clearly the first time, sorry. First time I've seen it.
No, my brain just couldn't get it the first time. My fault.
That, okay. Next question. For escalation of care, can that be the provider calling EMS to transfer patient to the ER, or would that be if they are sending them for possible admission? Is there certain documentation we would expect to see within the note?
Okay, let's talk about that one. I'm glad you asked this question. When when we're talking about sending the patient to the ER, that's really part of risk, which that's not what we're talking about today. We're talking about the problems. However, I do want you guys to know we just ran some data on situations where the patient's in the hospital, I'm sorry, in the office, in the ER, and in the hospital all on the same day. The amount of money that Medicare pays for those interim ER visits is astronomical. Um, if if you believe that the patient should be admitted to the hospital, obviously, if you have an urgent situation where you need to call an ambulance for them to go, do that, obviously. But if you want the patient admitted, but they don't have to go through the ER, then do a direct admit. Save the patient money, save the Medicare Trust Fund money. But that's part of our risk presentation, which will be next week, I believe it is. Next question.
All right, thank you for that, and thank you, Sam, for that question. Next question. A patient comes in for a 6-week follow-up on a complicated injury. The injury is healing well. Patient has no complaints. How would I categorize this injury?
Well, you're not treating a complicated injury anymore. So you want to look at what problem is being addressed today and what's the status today. Now, when you saw them previously, they had bones sticking out everywhere and your doctor fixed them, and so now they don't have that anymore. So now you want to look at your documentation and where does the patient's problem today fall into that. Based on what was said, we have a stable condition at this point. So you could fall into stable acute. Because it's still kind of happening. We're still going through the healing process on that. I think that would probably be where that one would fall in based on the information you gave.
Okay, thank you.
Mhm.
If the doctor states severe osteoarthritis level 4 in the HPI, would this be considered a high-level problem?
Hang on, let me look at my definition again. Okay, not without the additional information. You know, the word severe is good. That's good information. But when you look at high, the definition is one or more chronic illnesses with severe exacerbation. What's the exacerbation? What's the progression, or what's the side effects of treatment? That's what needs to be within the documentation to support the use of that level.
Okay. Next question. A differential diagnosis does not need to be documented to credit undiagnosed new problem with uncertain prognosis.
You may not have a diagnosis yet. You know, again, we go back to the abdominal pain. You're treating the patient for that abdominal pain. You may not know yet what's causing it. There could be CT scans, there could be lab tests, there could be, you know, whatever that you need to have done in order to figure out what that differential diagnosis could be. Now, if you're, you know, if your physician is thinking, well, it could be this or this, and he or she documents that, that's fine, but you don't have to have a differential diagnosis.
Okay. Once we query, does the provider need to amend the record?
If yes. Well, let me put it this way. If what they have in the record does not support what they're telling you back, then yes, they need to amend the record.
Okay. Next question from Julie says, follow-up to undiagnosed new problem. The definition of undiagnosed states a problem in the differential that represents a condition likely to result in a high risk of morbidity.
Mhm.
You also have to look at the diagnosis of morbidity. How does a coder determine in the problem such as an abdominal pain fits the definition of morbidity if a provider does not document their thought process on what they feel the real problem might be?
You don't. You know, and you have to go back to that physician or practitioner. You know, again, when we go back to the example of abdominal pain, the physician has to document what they believe that level of problem is. A differential you know, diagnosis could be appendicitis. Um, it, but maybe that's not what they're thinking. What is that physician? What's their proof of thought as to how severe and how intense a problem this is for this particular patient?
Okay. Let's see. Patient seen for CKD. In the past medical history, hypertension and DM are listed as chronic conditions but are not addressed. Do you code the CKD only and not the combination codes?
If your physician's documentation does not show that they addressed the hypertension or the diabetes, or how they used the hypertension or the diabetes in connection with the chronic kidney disease, then no, you would not count those as part of your problems. It all goes back to the documentation. What does your physician or practitioner tell you within the documentation that they are addressing on that particular day? And Aline will take one more question.
Okay, last question. And I've just been asking these in order. So if you have a question that we didn't get to, don't worry. This question, if a patient has cancer that has metastasized, would that automatically qualify for high complexity and condition posing a threat to life? Or is it about how the patient is doing on that date of service? For example, patient comes in for chemo and doctor documents patient has lung cancer with brain mets. Doing well today, will proceed with chemo. Would that be high complexity of problems?
Okay, so this is a really good question to end on. Because what is your physician or practitioner doing on that date? Patient is having chemo, and so are they evaluating that patient for the lung cancer, which has metastasized, or are they evaluating that patient for whether or not they can have chemo? Because that's very different work that your physicians and practitioners are going to do based on what it is they're doing. If that visit, if that encounter is simply to evaluate, yes, the patient can have the chemo today, then you're talking a pretty low level. If that patient, or a low level, let me put it that way, if the doctor is evaluating and treating the cancer, then that could be a higher level. So you really want to look at your documentation, and especially when we're talking about chemo, what are we doing today? Are we, saying yes, the patient can have chemo, or are we treating the actual illness or injury? And documentation needs to support that one way or the other. So as Aline said, that was our last question. Any additional questions contained within the chat, I'll be putting together along with any follow-up questions and then sending those back out to all attendees. That will probably be within 2 weeks of this. So on behalf of Aline and myself, we want to thank you very, very much for your attendance today. Again, if you have the additional questions, you can submit those. We do encourage you and ask you to take that survey for us. We do want your feedback. Have an absolute wonderful day. You can now disconnect.